Hi, my name is Stephanie Prendergast, and I am co-founder of the Pelvic Health and Rehabilitation Center. We have locations in the San Francisco Bay Area, Los Angeles, and in New England, and I currently practice in our Los Angeles location. I am co-author of the book Pelvic Pain Explained, and I am a former past president of the International Pelvic Pain Society. A few years ago, the International Pelvic Pain Society decided to designate May Pelvic Pain Awareness Month, obviously to help raise awareness about various pelvic pain syndromes. And here at PHRC, we wanted to do our part to contribute to the cause. Today, I'm coming to you with the fifth part in our five-part series, and today I'm going to be covering the topic of pudendal neuralgia. I've been working very closely with patients with this diagnosis since 2001. Since that time, physical therapy has become more and more important as far as treatment plans for patients with pudendal neuralgia. Over the course of getting treated and people's journey to recovery, there's many ups and downs that can occur. So today I want to take some of the fear out of the diagnosis and help restore hope. And one of the first things we hear when we're starting to work with somebody new is how difficult it was for them to get diagnosed. Along the way, many people may have told them they're not sure what's wrong with them or this is in your head. We expect that that's going to happen, and we want people to know that they're not alone when this happens to them. There is people who understand the diagnosis well, but there's still a lot of work to do for those people in the general medical community that do not. That does not mean that people with pudendal neuralgia have an unmanageable or an untreatable condition. It's just not that as many people as we would like are familiar with this diagnosis yet. Similar to some of the challenges people face with getting diagnosed, there's often challenges with the treatment plan. People may not be able to tolerate a certain medication that's prescribed, or a pudendal nerve block doesn't have quite the effect that you wanted it to. Maybe you can't find a pelvic floor physical therapist. In this lecture today, we're going to use our experience to show you different ways to troubleshoot these issues. And again, I want to reiterate that this is more common than not that these things are going to happen. So to start with knowledge being power, let's take a look at pelvic floor anatomy. The pudendal nerve has a pretty vast distribution in the pelvis. As you can see in this picture of female anatomy, there's three main branches of the pudendal nerve. One is a dorsal branch of the clitoris, one is a perineal branch, and finally there's an inferior rectal branch. This is responsible for the majority of the sensation in these areas where you see the nerve traveling. The men have a similar counterpart with the pudendal nerve, with the nerve innervating the areas that you see here, which is the perineal area, the base of the scrotum, again, surrounding the anal sphincter region. And in this picture, you can actually see the muscles as well. So in addition to the pudendal nerve supplying sensory information from various parts, it also controls the pelvic floor muscles, which you can see very nicely here. So when I say that the pudendal nerve is responsible for sensation, if one of these areas that is innervated experiences, let's say, light touch, then the pudendal nerve carries that information into the spinal cord and into the brain. When we look at the motor component of the nerve, let's say you want to do a Kegel exercise or squeeze your pelvic floor muscles, the pudendal nerve is partially responsible for taking that command from your brain to the pelvic floor and making those muscles contract. Many, I'd say, peripheral nerves in the body have these sensory and motor components. But what many nerves do not have is the autonomic component of the pudendal nerve. So you can also see here that the pudendal nerve innervates part of the urethra and anal sphincters. These areas are controlled by functions that do not require our brain to think about. So for example, you can think of as you go about during the day, you don't have to think about keeping urine inside your bladder as your bladder fills. Over the course of time, as the bladder fills throughout the day, the pudendal nerve gets signals from the bladder that that's happening and actually remains active to help keep that urethral sphincter closed to help us maintain continence. That happens without us thinking about it. Now, if you think about breathing also happens without thinking about it. People inhale and exhale throughout the day without a thought to it. However, if you chose to either hold your breath or breathe faster, you're able to do so. That's kind of similar to the pudendal nerve in that it has its functions that's carrying on throughout the day, but we also have the ability to override that. And examples would be doing a Kegel exercise, or when someone's ready to start their urinary stream, we signal the muscles to relax. Now, this autonomic component makes the pudendal nerve unique, as I've explained, and a little different than other parts of the body. The pelvic floor always has some tone to it, and because of that, symptoms of pudendal neuralgia and pelvic floor dysfunction respond a little bit differently to treatment than another part of the body, which we're going to get into today. So it's also responsible for clitoral and penile erections. The nerve is involved in orgasm and ejaculation. It's involved in urinary continence, as we described, but also fecal continence. And it innervates the pelvic floor muscles, which are very important for supporting all of our pelvic organs and keeping them in the places they belong. So in a short sentence, the pudendal nerve is kind of a big deal. And the things it does when it becomes dysfunctional can affect any of the areas that I just mentioned. And so patients may present with a host of symptoms that are scary and alarming, but again, very treatable. So to start with understanding how the pudendal nerve can become dysfunctional, there's 5 general, for simplicity purposes, categories that we see patients encounter. An example can be compression injuries, such as the cyclists, horseback riding, people who sit a lot during the day. There can be tension injuries, which would be things like chronic constipation. The straining of constipation can put a lot of tension on the pudendal nerve, as well as squatting will lengthen the nerve under pressure in situations. Childbirth is another common example of a tension injury to the pudendal nerve. There can be surgical insults, meaning that people are undergoing a surgery for something else, such as pelvic floor reconstruction, and perhaps something went a little awry during the surgery and the nerve became involved. There can be trauma to the nerve. As I mentioned, there can be childbirth injuries or accidents where the bony pelvis is disrupted. Unfortunately, we've seen cases where people have fallen and the pudendal nerve has gotten involved because the skin has been ruptured and the area around the nerve was vulnerable. There can be infectious and disease causes, such as repetitive yeast infections and some other dermatologic diseases. Some other gynecologic diseases can actually cause a loop of viscerosomatic pain, which can then in turn sensitize the pudendal nerve. And then in some cases, we're not quite sure. Hopefully over the course of treatment, the people who aren't sure of what their cause was will likely figure out what could have been some of their inciting factors. And some people can have a few of these things, some people can have multiple, but often there is usually a reason why these symptoms developed that in physical therapy we can help you figure out. Now, a very common question people have is, well, plenty of people cycle and plenty of people ride horses and they don't get pudendal neuralgia, so why did I? Well, the basic simple answer to any pain symptom in the musculoskeletal system is that once your body exceeds what that particular body part can do, some sensitivity may occur. The muscle can become painful, the nerve can become irritated. It's when that particular structure's limits are pushed. And that is going to be different for everybody, depending on their anatomy, their body shape, the activities they're doing, what they're capable of doing. Another example is, as I mentioned, sometimes squatting can lead to tension injuries on the pudendal nerve. Why can one gentleman do CrossFit and somebody else can't without these symptoms? As we get further into the physical therapy evaluation and treatment, we're going to explain exactly why and how. So, once the symptoms appear of pudendal neuralgia, nerves have very specific symptoms associated with them. And those characteristics are burning, shooting, stabbing, itching, altered sensation, or numbness in the pudendal distribution. Again, similar to the causes, people can have some of these symptoms, they can have some of these symptoms coming and going, and they can have a combination of these symptoms. But it's important that it's not aching, it's not soreness. Those are characteristics more of muscle dysfunction. Nerves have a different presentation. With pudendal neuralgia, because of where the nerve is, the symptoms are often worse with sitting, which we'll talk about. They can get worse with exercise. They are affected by urination and bowel movements, orgasms, and some people have specific triggers, such as bending over or trying to squat down provokes their symptoms. Another interesting feature of nerves is that they can have acute and delayed onset of symptoms. So an example of an acute symptom of pudendal neuralgia is bending over to pick something up off the floor and getting sharp, shooting, zinging pains somewhere in the territory of it. A delayed onset is a little bit different. This is when somebody exercises, let's say, for example, and it may be activating the nerve a little bit, but not enough to create symptoms in the moment. Sometimes the nerve can produce symptoms in the territory that come on 30 minutes to an hour to a few hours later. This is called hyperpathia, and again is a feature of neurologic and neuropathic pain. Another common trigger in that category is somebody will be okay, they wake up, they're pain-free, they have a bowel movement, and 30 minutes later they start with urinary frequency, vaginal or penile burning that was triggered by the bowel movement but didn't happen immediately. Again, this can be concerning. The symptoms are painful, but it's not a reason to be alarmed. It's just the features of a nerve, which again may be different than other injuries if you've had them that you've experienced before. So as we started to prepare these webinars, we took some questions from social media, and we had some really good questions and wanted to use this as an opportunity to answer them. So a very popular and common question is there a way to tell between pudendal irritation and pudendal damage? So in order to answer that question, we should kind of take a look at the terminology that's used and what these words actually mean. So the terms that you may hear with pudendal neuralgia are obviously pudendal neuralgia, pudendal nerve entrapment, pudendal neuropathy, pudendal nerve damage, and pudendal nerve irritation. What is the difference between these terms, and is it important? Yes, the answer is it is important, and these different etiologies and different presentations can affect the treatment plan, which is why it's important that we all get on the same page with what these terms mean and what it means for their treatment plans. So to take a look at our colleagues in France, many people have heard of the Nantes group. This group was the first to identify pudendal neuralgia in the late 80s, and at that time it was actually acknowledged as cyclist syndrome, and it was thought to mostly be an entrapment issue caused obviously by a bike seat at Alcock's Canal. And so when there was what was thought to be an entrapment, the reasonable treatment for that was pudendal nerve blocks and a surgical intervention. During that time, it was difficult for the team to figure out who had entrapment and maybe who just had pain. And so they introduced a series of electrophysiological tests. These were called the pudendal nerve latency test, EMG testing, stage sacral reflex testing, and quantitative sensory testing. And they wanted to see if these findings on the tests were positive, if that correlated with their surgical findings, meaning that these tests should be used as indicators to warrant surgery. What the group concluded with their years of research is that these tests, in fact, do not bring in or rule out pudendal nerve entrapment. That's kind of good news because these tests are very painful, they're not readily available, and in the end, they're not telling us if surgery is needed or not, so mostly these are no longer used. Because these tests could not rule in or out pudendal nerve entrapment, the group went on to say that because of the absence of these tests, a diagnosis of pudendal neuralgia needs to be made in the clinic. The only way to determine if nerve entrapment is in fact or was present is to undergo the pudendal nerve decompression surgery, and if visually the nerve looks like it had been entrapped and then there's a post-operative finding of symptom relief, it was likely that there was in fact an entrapment causing somebody's symptoms. This research was published in 2008, and again, there's been a lot of advances in how we think about this since that time. So the clinical criteria that the team is referencing is pain in the territory of the pudendal nerve, pain predominantly with sitting, pain that does not wake the patient at night, pain with no other sensory impairments, and pain that is relieved by a diagnostic pudendal nerve block. Now, some people may wonder, what about the other diagnostic tests? Because they're hearing that 3 Tesla MRIs or pudendal nerve neurography may be useful in helping people diagnose pudendal nerve entrapment. So as the time went on, again, these tests have been looked at and compared to the surgical findings. And unfortunately, the same thing happened as with the electrophysiological testing, in that imaging did not do as much as we wanted it to. It may give you some more information about the nerve, but it can't rule in or rule out pudendal nerve entrapment, unfortunately. So one of the criticisms of these tests is that the characteristics of pudendal neuralgia are movement. Some people have problems with sitting, some people have problems with bending over, some people have problems with running. And when you have these imaging techniques implemented, you're static, you're lying down. A lot of people don't have pain lying down. So one of the theories is why they're not as useful as we would want them to be, is they're not actually capturing what's happening with the nerve. Nerves need to slide, glide, and move. They need to be able to receive oxygen and blood supply from the nerves and arteries. And when it gets compromised somewhere along the path of it, we are going to see symptoms. And unfortunately, the electrophysiological testing and the imaging may not catch that dynamic ability of the nerve to move like pelvic floor physical therapy can. So to go back to the terminology, I think pudendal neuralgia is an accurate term to use for people with the symptoms that we described. Because we can't confirm pudendal nerve entrapment outside of surgery, and many people haven't had surgery, this term is probably not accurate to use. Pudendal neuropathy is a broad umbrella term that includes pudendal neuralgia, but it can also include other forms of pudendal nerve injury, such as complete motor loss, which is very common or most common in something like childbirth. This is a situation where the nerve has been involved, and that therefore affects the pelvic floor. The woman may be experiencing complete urinary incontinence, fecal incontinence, but she might not have pain. So the umbrella term of neuropathy also includes situations where there may be other factors involved, not just pain. Pudendal nerve damage is another tricky term, because how do we prove that there is damage? And it sounds very limiting and it sounds very dire. We can't prove that there's damage to the pudendal nerve. Therefore, I think a better term to use is pudendal nerve irritation. Kind of synonymous with pudendal neuralgia. If you're getting these symptoms, then likely there is something happening and there are impairments somewhere along the course of the nerve. So how do we determine where those problems are? That's important, because how do we help people get past them? So the first part of a physical therapy evaluation is to help our patients understand, how did I get here? We're going to ask very specific questions about the past history, looking to identify things in their history that we think could have been a trigger. There's often comorbidities or other medical conditions overlapping, or biomechanical situations that may have predisposed our patient to get pudendal neuralgia, whereas someone else did not. We also need to look at the central nervous system and how the effect of pain has affected the nervous system. Specifically with neuropathic pain, that's going to render the central nervous system to undergo changes as well when pain persists. There's been a lot of advances lately in pain science education and really understanding what happens when somebody experiences persistent pain. It's just as important to address these central nervous system changes as it is to address the possible mechanical causes of why the pain is there. And that is something that we can assess in physical therapy. Next, we want to understand how the pain is affecting someone's life, both at work, at home, how they're coping with their pain, what treatments they've had so far, what has worked and what hasn't. This is all going to become part of the individual person's narrative as to why they are in the situation they're in. Oftentimes here at our clinics, we are seeing people who have failed other treatment plans. And when I say failed, maybe they didn't get to the outcome that they wanted. But again, there's usually a reason for that. And hopefully we can help somebody figure that out. We also want to ask questions, as I mentioned, to identify other factors that may be involved. Following the question and answer period, we move on to the physical exam. Now, pelvic floor physical therapy exam includes a lot more than just the pelvic floor muscles, especially for somebody with pudendal neuralgia. So basically, at least we're looking from the ribs to the feet. We're looking at the mobility and density of the connective tissue, particularly in those areas around the nerve inside that bony pelvis, in the posterior legs. We're looking at pelvic girdle muscle evaluation, which is different than the connective tissue evaluation. So any of the muscles attaching to the pelvic girdle can influence the position of the pelvic girdle, which can in turn influence the pelvic nerve. That can also influence the pelvic floor. The hip joint, specifically the lumbar spine and the sacroiliac joint, all can also have a significant impact. And then finally, and also is equally important, we need to see how people are moving. When a physical therapist examines movement patterns on somebody, we're going to look at things that may not seem as obvious to the naked eye. We are specifically trained to identify areas where the neuromuscular system isn't working properly. And over time, regular activities such as walking or exercise can lead into symptoms, again, if the demands on the body are exceeding what that particular body part can do. When we get to the internal portion of the exam, we will visualize and inspect the skin. We're looking for other things that can also be a factor, such as menopause, hormonal influences, dermatologic situations, such as lichen sclerosis. These factors can also contribute to the symptoms that people have and are often present with some of the other things. So we want to make sure we're covering all of our bases. We will do a sensory screening to identify hypersensitivity, altered sensation, lack of sensitivity. And finally, we also have to examine the pelvic floor muscles. We are looking to see how those muscles function, the motor control that an individual has over those muscles. Are those muscles sore? Are they compressing the nerves at various points? Are they strong? Are they weak? All of these things will come into play. And then finally, there's a test that you can do clinically called Tinel's sign. And this involves us palpating the different nerve branches. So generally speaking, there's 6 easy access ways where we can palpate pudendal nerve. That's at the dorsal branch, at the perineal branch, which can include Alcock's canal and the ischial spine, and at the inferior rectal branch. If we touch these nerve branches and elicit a sharp shooting, stabbing pain or a reproduction in somebody's symptoms, that's when this test is considered positive. And specifically, the pudendal nerve is demonstrating irritability at that place where we touched. So I think one of the more interesting components of our jobs is really putting this story together. So after we've done the history and we found the physical impairments that somebody's presenting with, we want to link the things in their history that may have led to the development of the objective findings that we are seeing that we think are causing their symptoms. So it's not as straightforward as people would like. Often there's 3 or 4 structures that irritate the pudendal nerve, let's say at Alcock's canal. There's different structures that may irritate it at the dorsal branch or at the tailbone area and the inferior rectal branch. So each individual treatment plan is going to vary based on the impairments that we find and the influence that we think that that's having on their symptoms. So we help our patients understand that, including the areas that they may have had when we reproduced their symptoms in the clinic, should hopefully be reassuring that we're identifying those structures, which means we can also treat them. We need to establish the frequency and duration of treatment. Typically, patients are seen in our clinic, if they live locally, once a week for an hour. And the duration of treatment is going to vary significantly based on the severity and the chronicity of somebody's problem. But in general, I'd say most patients will be in physical therapy for usually at least 3 months. We want to establish short-term and long-term goals. So this is important because physical therapy can change things slowly over time, going towards the bigger picture of functional changes. So example of short-term goals that we set, this is something that we expect to see in about 4 weeks. So for example, if Mary had severe pelvic floor hypertonus that I think was contributing to compression of her pelvic nerve or her pudendal nerve, we would want to use the next 4 weeks to treat that, to try to change the hypertonicity. Can we decrease that in 4 weeks with the intention of eventually, excuse me, with the intention of eventually taking the pressure off the nerve and relieving that nerve. We'll see smaller changes before we see bigger changes. So another example would be to decrease pelvic floor muscle tone in order to initiate easier the urinary stream, or to decrease the burning somebody feels with urination. We may see changes in things like urinary and bowel function and improvement in these areas before we see a change in the more severe symptoms such as burning. So it's important to set short and realistic goals that are reevaluated each month to make sure that we're headed in the right direction. Longer term goals include things like Mary will be able to sit for 4 hours without a cushion. And all of the little short-term goals we're setting are going to help her get to that point. Or Bob will be able to have intercourse and not experience post-ejaculatory pain. Matt will be able to return to CrossFit and not feel the symptoms of shooting pain in his perineum. We're going to figure out which symptoms are causing which impairments are causing the symptoms, treat them over time, and eventually the symptoms are going to resolve. Case management is a huge part of the physical therapy treatment plan because we are the people who are afforded the most time with our patients. In our clinic, we spend at least an hour with each patient each week. And during that time, we can also understand the other medical needs that they may have. Physical therapy is going to tackle a lot of the biomechanical issues, but there also can be central nervous system issues. There may still be disease processes going on. There may be severe pain that doesn't allow somebody to tolerate physical therapy right away. We are responsible for evaluating which other therapies will be beneficial for our patients and also providing them information and education about that so everybody can make a decision about the treatment choices that are right for them. And again, it's going to vary from person to person, and what works for some person will probably not work for another just because of their history, their impairments, all the things that we're talking about now. Okay. And finally, after we start to establish the case and the team, we also want to talk about what patients can do at home, because that is very crucial to helping support what we are doing in the clinic. And again, just review what the expectations are with frequency and duration. Every time a patient leaves our clinic, I want them to know what the plan is for the week, why we're doing that plan, what symptoms I expect to still be there, what symptoms I expect to be different, and just understand how this process works. It's also, we've been noticed with our experience that many people have, I'd say, a lack of information about how this process should work, what the pudendal block was supposed to do, what the medication is supposed to do, and how physical therapy is supposed to change over time. We need to have a constant dialogue to make sure everyone's on the same page, which really will help decrease the fear and anxiety around the process. I mentioned temporary lifestyle modifications because sometimes at different points during the treatment, we may have to modify the activities that people are doing. If the goal is to return to cycling, we will make sure that that patient gets there, but there may be a period of time where that may not be appropriate, especially if we're trying to decrease significant irritation. With proper patient education, I think that we can neutralize fear. We need patients to understand what persisting pain is and why it's different than acute pain. And once people understand that, I hope this seems less scary. Okay. So another popular question that we get is, how do we know if this pudendal neuralgia is pelvic pain because of the muscles or if it's because of the nerve? Well, a key thing with pudendal neuralgia and why pelvic floor physical therapy has become such an important part of the treatment plans is these things often go hand in hand. If we think back to the anatomy and the pelvic or the pudendal nerve controlling all of the pelvic floor muscles, if the nerve gets irritated and there wasn't pelvic floor muscle tightness, people will often start to develop pelvic floor muscle tightness because of the nerve irritation. Conversely, somebody may develop pelvic floor hypertonus, but they may not initially have nerve irritation, but over the course of time, they start to get nerve symptoms as well because the muscles are compressing the nerve. There's many other examples I could use, but hopefully that is basic enough and that makes sense. So typically treatment is going to evolve addressing both of these areas. So I think explaining how this can work is best used with an example of a case. And as we've been doing all month, we're going to publish a blog that's associated with this webinar that will have all the things I'm mentioning in there, including a success story from one of my patients. So to review her case, she came to me last August, and she had had symptoms of vaginal burning and urinary hesitancy that began on a long road trip. So she was prescribed gabapentin for the vaginal burning, which she thought helped a little bit, but she still couldn't exercise, sit, or have sex. She underwent pelvic floor physical therapy for a year and again thought it helped somewhat, but it wasn't getting her to her goals. So as someone comes to me with this history, of course I'm wondering, why didn't pelvic floor physical therapy help her? What else is happening? What went wrong? So during the course of her evaluation, we identified several external structures that were contributing to her symptoms. One of her symptoms was she couldn't bend down to feed her dogs without stabbing pain in the vagina. When we assessed the way that she bent down and moved and did a squat, she had different neuromuscular patterns than somebody else. Why was that? She had very tight external rotators of the hip. The external rotators of the hip include the obturator internus, which houses the pudendal nerve. So during the course of her time in physical therapy, that muscle had never been addressed. So that could have been one reason why, and I suspect it was, that she didn't ever get to the point where she could do that activity despite long physical therapy. When I examined her pelvic floor, that was completely normal. She didn't necessarily have any tenderness in the pelvic floor muscles, which one should expect after a year of internal therapy. She did have external connective tissue restrictions in the area inside her sit bone, which likely was getting compressed when she tried to sit, which was causing some of the burning. So for her, I think two areas that were missed were some of the connective tissue dysfunction and the hip rotators. And so that's what we started to address in physical therapy. As we started to make changes in those areas, she was getting better in terms of the objective things that we saw in the clinic, but her symptoms were not necessarily catching up, which is not an uncommon thing to have happen. If the nerve irritation was coming from long-term muscle compression, it's almost like turning the burner off, but the stove is still hot. And if that's not changing over the course of time, which it wasn't for this particular woman, we decided it may make sense to reconsider better pain management to help reduce the consequences on the central nervous system. Her nerve was not tender to touch, yet she had symptoms of pudendal neuralgia. Because her nerve was not tender to touch, it probably doesn't make sense to initiate something like a pudendal nerve block, which we do see as an effective strategy when the nerve is very irritated. There's positive Tinel signs. People with those findings tend to respond better to pudendal nerve blocks than someone in her situation. Her pain management doctor agrees with this theory and suggested switching her from gabapentin to Lyrica, and also introducing Effexor, which is a serotonin and norepinephrine reuptake inhibitor, which has efficacy for helping to reduce neuropathic pain. When we made the switch to these medications, her symptoms quickly started to reduce. Now her question, and it's a good question to ask, is why didn't the gabapentin help initially? Initially, when she started with physical therapy, it helped a little bit, but she had very mechanical causes of her symptoms. And so therefore, it wouldn't be expected that this medication is going to take away all of her symptoms when day-to-day walking and moving could re-irritate her nerve. Once these things started to clear, she was better positioned to respond very well to the medication, which for her was her choice. And subsequently, her symptoms have resolved. And now, about a year later, we could say that they are still resolved, which is great. So I always think that this algorithm is so important when people are feeling anxious or they're not sure why they're not getting better. If we take a look at the top of the algorithm, patients with pelvic pain, once other pathology is ruled out, need to enter a treatment plan that should be interdisciplinary. Physical therapy is almost always involved in these things, but other strategies may also be helpful, and some of these things may be helpful for some people more than others. For example, in Sham's case, she was somebody who had long-standing nerve irritation and then eventually responded to medication. Other people may not be able to tolerate medications, and that's fine. If they can't tolerate medications, there's other strategies that could also help reduce central nervous system irritation. These can include mindfulness, these can include acupuncture, which are some other bubbles that you'll see here. These can also include other interventional pain medicine techniques, such as the pudendal nerve block, like I mentioned. The important thing is to understand why you have the pain that you have, and then make targeted efforts to treat those things. None of these treatments just treat pelvic pain. All of these things can be helpful in the process, but it needs to be more specific than that. Physical therapy can specifically help pelvic pain that is stemming from muscular issues. If a person doesn't have muscular issues, physical therapy may be less important for them. We can always come up with another option within this strategy if someone is not responding or if they're not tolerating things. As we can see with the loop, we like the 4-week intervals. We need to reassess where our patient is after 4 weeks of a particular treatment, and then figure out if there's something else in here that needs to be introduced or something else in here that needs to be removed. For example, some patients who are taking medication may experience constipation, and that constipation triggers bowel movements that are painful because they're straining. If the constipation side effect outweighs the benefit of the medication, we may need to switch that medication, and that's okay. We can. There's always another option available. So trying to think of this as a dynamic process that's going to have ups and downs will be more successful than thinking of it in terms of a simple cause-affected treatment. Which leads us into a common question, which is sad to me that people ask so often, because I know many people are struggling. Is this actually reversible? Do people actually recover? Yes, they do, but there are ups and downs, and it may take longer than you would think because of these unique properties of the nerve and the unique properties of the pelvic floor. It's not going to respond as a simple hamstring injury or even severe low back pain, but it will respond. And keeping that in mind should help ease the process that people are going through. Again, hopefully this presentation is replacing fear with hope and helping people understand that help is available. So in addition to the things that we help with in a clinic, there's a number of things that can help people at home. In the post, again, that I'm going to be releasing after this webinar, there are links to all of these things. There's many things at home that people can do that we find helpful. Here's a few of our favorites. For external pelvic girdle muscle dysfunction, we like the foam roller, the stick, the Theracane. For internal therapy, we like the pelvic wand or the TheraWand. There are a number of cushions that can help patients, but it's important that you find a cushion that's right for you. There's not one cushion that's right for everybody because they're going to have different tissue involvement, different bony pelvis involvement at different areas. So some cushions may actually be irritating for people, and if they are, then we need to figure out why and switch to something that is not. Time and time again, there has been very good research that meditation and mindfulness helps reduce persisting pain symptoms and the effects on the nervous system. I am not implying that breathing exercises are going to take away pudendal nerve pain, but we know that these things do help. And so if a patient only has 20 minutes a day and they have to pick one thing to do, I think the meditation is a good choice. There are a number of apps out and tools that can help. So again, here are a few of our favorites. There are different things that can help you monitor your breathing. There are certain things that can help you calm down in as little as 5 minutes throughout the day. There's things that can help you within your home, and even the Apple Watch has apps. Another key thing that we've talked about today, and that is always part of our treatment plans, is really getting up to speed with the pain science education. This is something that's been newer, I'd say, in the last 10 years, that is now really entered mainstream, but not all people are educated or have the time to explain how the central nervous system works for patients. If you have one website that you're not familiar with, that you haven't looked at, we love Tame the Beast. It has different modules to help people first understand how pain works. Podcasts, videos that you can listen to. Everybody learns differently. And then also strategies that you can use at home to help calm your symptoms. Now, another question that comes up is, I need to work specifically with somebody who treats pelvic pain. Yes, that is important, but also pain is pain is pain. And some of the strategies presented here will work for all types of pain because it affects the central nervous system. Next, there's also a number of organizations. Well, no, there aren't a number of organizations, but one organization provides a number of resources available, and that is the Pudendal Neuralgia Association. And again, the people who are behind this, we want to thank, because they are also working very hard to raise awareness and help people who aren't as informed, doctors, patients, families, get more informed about what this diagnosis is. There's also a number of support groups that you can find through their website. And obviously finding medical providers is important. So International Pelvic Pain Society, as I mentioned, does have providers, physical therapists, doctors, psychologists. The American Physical Therapy Association also has registered physical therapists, Herman and Wallace, and finally Pelvic Guru. Also, we think our book is a good resource for people with pelvic pain. And if you haven't read it yet and you don't subscribe to our weekly blog, you may do so. And all month for Pelvic Pain Awareness Month, we are giving away free books. So please go to our website on the homepage, fill in this form, and we will be notifying you via email if you are a winner. Please stay connected with us. Again, we publish a weekly blog trying to provide reliable information for people about all the different pelvic health concerns. We're on Facebook. You can find us on Instagram and Twitter at Pelvic Health. And if you thought this was useful, you have more questions you want answered, please reach out to us, because I have a feeling that this is something we will be doing again. I hope you found this helpful, and we do wish you the best with your recovery.